All right, so welcome guys to today's CPR session. We're going to be going through the Paramedic Emergency Skills Program today. It's an 8-hour training day, and the group that we have here, we've got two instructors, myself. I'm Shane Eichmann, an educator, outreach coordinator at CPR, which is Hamilton Health Sciences Center for Paramedic Education and Research. We've also got the privilege today to have a couple of our midwives here. And I'd like to start off by thanking, obviously, the Association of Ontario Midwives in the creation of this collaborative program. The skills that we're going to be going through and the content today will be based off of an 8-hour day, and most of it is hands-on. So we will be doing some presentation in the morning, going through the different deliveries, normal and otherwise. And then in the later part of the morning and the afternoon, we'll be doing hands-on skill stations. So you guys will get lots of practice rotating through the skill stations and doing scenarios to simulate emergency childbirth in the field. So without further ado, I'll introduce Annabelle here. And then we'll get started. Annabelle's going to start off with the presentation, and then we're going to kind of swap out midway through, and then she'll take the latter half of the presentation as well. So, all right.
Sounds great. I'm Annabelle. I'm a midwife that's been practicing for 7 years in Toronto and helped develop this curriculum for paramedics. So thank you for having me here today to present it to you. We have Shirley here as well as support as a midwife on site. So welcome.
I'll get you to put that on there.
Okay. Great.
There we go.
Great. So welcome. Shane's reviewed the agenda, but basically the way I see this presentation is most of you probably got the emergency childbirth manual to read ahead of time. Yeah? Did you all get that manual? So this presentation is supposed to bring the evidence and the research that's in that manual to life. So it's a very quick kind of background, evidence-based information for the next hour and a half. And then the key here is hands-on. As soon as you can get your hands on to the torsos, the dulls, the placentas, the bony pelvis, that's going to really help lock in this learning. So this presentation is just sort of a high level, make sure we're all up to speed from the manual before we move into the hands-on. Okay, and our main chapters today that we're looking at is we're going to begin with uncomplicated childbirth, and that includes precipitous birth, so a fast birth. And we're going to go into shoulder dystocia, we're going to look at malpresentation and cord prolapse, we're going to look at twin birth, multiple gestations, breech birth, denied or hidden pregnancies, so those calls you might get where a pregnancy is actually unknown. And the risk there is that often that population has not had any antenatal care. So we'll be really looking at what does that mean as paramedics showing up with somebody who's got an unknown pregnancy, or other at-risk populations that haven't had any prenatal care. And then of course postpartum hemorrhage. So those are our sort of 7 curriculum modules we'll be working through. So just to orient you to the Paramedic Emergency Skills Program, which we call PESP, our goal is that we really hope that you will leave here today actually feeling like you've developed some confidence around these emergencies and a toolkit that you're going to go out there with some skills. And what we find in the way that we teach it with repetition and collaboration, that there really is a level of learning that's considered transformative once you do the hands-on. So that's the goal today, is that you're going to leave actually feeling way more confident about attending to a call that's related to childbirth. So I just reviewed our main goal, and it's actually reflective of what OBAG wants for all of you, is that we're providing you that emergency childbirth skills to meet the requirements of OBAG and that medical directive that gives you ALS and learning objectives. So we're going to go through simulated emergency scenarios. We're going to self-reflect and debrief the performance to increase that confidence. And we're going to cultivate a safe and respectful learning environment. So it'll be fun, it'll be safe and respectful, and It'll be great. The AOM, as many of you know, the Association of Ontario Midwives, we've been teaching emergency skills for years, and in the last few years we've very much shifted to using adult education principles in our learning, and our midwives love our emergency skills program a lot more because of this framework, and so that's why we've developed the paramedic program with the same framework. What we understand is that all of you are likely really motivated to gain this knowledge, and that you have experience probably attending to childbirth, that you're self-directed in your learning, and that you're motivated. And then when we apply those principles to our skills stations later, where you're going to repeat the skills, you're going to be the primary paramedic, you're going to be that partner paramedic supporting that primary paramedic, and you're going to be an observer. Once you participate in a certain scenario 3 times, it really helps with that transformative learning. And you'll be collaborating and reflecting after each go around in the hands-on. So midwives and paramedics are really the only 2 professionals that will attend to patients out of hospital giving birth. And so it's a wonderful interprofessional collaborative project here that we will be sharing our knowledge. So it allows both of us to share our knowledge and communicate together and contribute to more effective patient care and communication in the community. In order to build on and encourage continued midwife-paramedic communication, the AOM is going to offer 2 webinars over the course of the year for all paramedics that have done the PESP, so that we can actually have some case reviews. You could maybe bring a case of an emergency childbirth call that you took, and we could support each other and have a knowledge share. So over the year, we'll come up with a couple of webinars, and that'll be part of this out-of-hospital emergency childbirth program. So as many of you probably have overlapped with midwives before, we're primary healthcare workers, we're regulated professionals, we have a college of midwives that regulates us. We provide primary care to patients that come in when they're pregnant, and we provide that care all the way through the pregnancy. We're on call for their labor and birth, and then we provide care for that person and the newborn for up to 6 weeks postpartum, and then we discharge that family out into the community. We are specialists in out-of-hospital birth. A lot of our clients, we refer to our patients as clients. A lot of our clients, if they're medically well and that we consider it a low-risk pregnancy, then there's lots of choice around birthplace. So many of our clients will choose hospital birth, home birth, or birthing at a birthing center. So we have a couple in Ontario, maybe 3, right? And we manage emergencies according to our defined scope of practice, which is a little different from your scope of practice. So we've adopted our emergency skills program to match your scope of practice. And we're typically associated with a midwifery group. We're available to our clients 24 hours a day because we carry pagers, and we have admitting privileges to local hospitals. Aboriginal midwives are recognized under the Regulated Health Professions Act as primary care providers too, and they're not under a college, they're under the authority of their home community and a community-based regulatory process. So an example of this is Six Nations Birth Centre, which is staffed by Aboriginal midwives and who I believe have close working relationships with paramedics and doctors at the local hospital. Home birth rates, just out of curiosity, from April 2014 to March 2015, so a 1-year span. A lot of people think most midwifery clients have out-of-hospital births, but in fact our data shows that about 16% have home births, 2% birth at a birthing center, so we're looking at 18% of our total population, and 81% plan a hospital birth. And 82% of those births are vaginal, and 16% are C-section. As you know, you probably know, we order routine blood work, we order ultrasounds, genetic screening, all of our clinical appointments, we're measuring the fundus to make sure adequate growth, we're doing blood pressure checks. Those clinical appointments involve all of that care. This is just a quick snapshot of our out-of-hospital gear, and really we consider it bringing up a pop-up level 1 hospital into every home assessment for labor, and for a planned home birth we set up this gear. So we have autoclaves, and we sterilize our birth instruments. We have suture instruments over here. We carry oxygen for the birthing patient. We carry oxygen for the babe. We have everything for neonatal resus. So we have a pulse oximeter, bag and mask, suction. We actually have intubation skills, so we have all the intubation equipment. Over there you'll see, your standard Foley catheter, your IVs. We have anti-hemorrhagic drugs, so we typically bring oxytocin, Hemabate, ergonavine, misoprostol, and all of that is set up. Basically, mom's corner is here, baby's corner is here, and if we're lucky, not much of it is used with a typical uncomplicated birth, but it's all there for just in case. And there's always 2 midwives at every birth, so a primary and a backup, and often there's a student there as well. Typical reasons for transport. I would say these are the 6 main reasons, and often pain management is not an emergency, but it's been put under this sort of urgent transport list. So pain management is a typical reason why we go in, and we usually wouldn't be calling an ambulance for pain management, but this just exemplifies one of our reasons why we don't stay at home, is to go in, and most commonly to get an epidural if it's too long or too painful. The next one is abnormal fetal heart rate. So we listen all the way through labor. We auscultate with a Doppler, and if we're concerned about an abnormal fetal heart rate and that client is in second stage and pushing, we'll likely call EMS, because that'll be really hard on that person pushing with a bad heart rate, and we need to get in. So that's when we would be calling you. Shoulder dystocia, our job is to get that baby born. Having paramedics there for shoulder isn't about necessarily needing emergency support to get the baby out. It's that what are we left with afterwards? We could have a compromised baby or a massive tear or an increased risk of a hemorrhage. So that's likely why we would be calling EMS with shoulders. And you'll be learning today that after 1 or 2 maneuvers, that's when midwives are calling to say, just in case we have a resus or a hemorrhage, we need support. Postpartum hemorrhage we might call. Often we can stabilize a hemorrhage, but then we want to offer that patient to go in and have continued monitoring in the hospital afterwards. Malpresentation leading to cord prolapse is that real, true, urgent emergency. So if a midwife ever pages with a cord prolapse, then that is something we'll be really reviewing today. That is so urgent, and we need to get in and expedite a C-section. And meconium, again, if that's coupled with dystocia, a slow labor, or abnormal fetal heart rate, then we're calling for support with meconium. Any questions so far? Can you keep going? Okay, so we're going to ground this curriculum in uncomplicated childbirth and just give you a high-level overview of the stages of labor, the mechanisms of labor and birth, how you deliver a baby, which many of you have probably done, and delivery of the placenta, or the 3rd stage. I know that one of the key parts of the medical directive is teaching around the umbilical cord. So how do you treat the umbilical cord? So we'll be really focusing on that in this section. And then also a key piece is delivering the placenta. The medical directive really wants to make sure that paramedics feel comfortable with the basic steps to delivering a placenta if you need to, and we'll go over why you might need to. And then throughout all of these sections, there's a focus on patient assessment, preparation for birth, and equipment setup. And this is one of the main reasons why OBAG came to us rather than OB-GYNs for this curriculum, is they've got all, obviously, that evidence and that training in birth, but what they couldn't bridge was how do you do this out of hospital? How do you do this roadside? How do you do this in the foyer of an apartment building or in your rig with your stretcher? And so they said, okay, the midwives do out of hospital birth. Let's get them to lead you through that patient prep and equipment setup. And we'll also focus a little bit on documentation. What are some key things that you might want to be remembering through each of the emergency childbirth skills to document? So uncomplicated childbirth, it's when that labor starts itself, it progresses all the way through to a spontaneous vaginal birth and the baby's head down in a vertex position, and that baby is at term. Full term we consider between 37 and 42 weeks. A fast birth is one of those births that happens from beginning to end in 3 hours or less. So often in a primip, which you likely know is a first-time pregnancy, a primip is first time, multip has had subsequent pregnancies and births. So in a primip it's quite shocking if she's only had mild contractions for an hour and then suddenly it's rip-roaring labor and she can be caught off guard. Same with multips. They could have had a 12-hour first labor and birth and be quite surprised that this one is happening quickly. So it's that 3 hours from beginning to end, and the things we want to convey, they're pretty much intuitive, but with a precipitous birth, you actually want to get that person into an anti-gravity position. So if that person's upright or on the toilet, that's going to expedite that rapid birth. So intuitively, it's get that person side-lying or supine, get the gravity off, and try and slow things down. You don't want a rapid expulsion of a baby. You've got increased tearing and bleeding, and there is that head compression and expansion that can potentially lead to intracranial hemorrhage. So you really want to try and encourage anti-gravity. We're going to show you how to guard the perineum and place a little bit of counter pressure on the head as it's crowning to make sure that that head is delivered in a nice slow way. And then be prepared to stimulate. Often these babes are fine after a precipitous birth, but they can come out stunned. They can actually have that big Moro reflex and eyes wide open but not breathing. And that's a baby that's born quickly, and it's often the best remedy is skin to skin. We know that skin, heat, heartbeat, mother's respirations actually help a baby transition a lot better. That's why we really do go skin to skin, dry and warm that baby, stimulate that baby, and they'll likely come around pretty soon after. And then with precipitous birth, you do want to have a little bit of more awareness that there's an increased risk of postpartum hemorrhage. Sometimes that uterus can be tired, and you'll want to be more alert for signs of placental separation and needing to deliver that placenta, which we'll go over in a bit. Just a note, high-risk patients can have uncomplicated births too, which is really lovely. So they can have all kinds of medical conditions and lots of monitoring, and then they can have this kind of birth. Obviously best to get in right away for whatever those underlying medical conditions are, but this doesn't preclude high-risk pregnancies. And then third stage is, actually, where are we at now? Stages of labor. Okay. So labor is continuous. It's got a start and an end, but we do typically define it by 3 stages. So the first one is that dilation, where that cervix is opening all the way up to 10 centimeters. And there is an early labor that can be long and drawn out, where that patient reports feeling crampy, low back pain, mild spotting and bleeding, and that can actually be a significant amount of time. Active labor is truly when we start that clock of labor, and that's when they are really coming every 4 to 5 minutes, lasting 45 seconds to 60 seconds long, and that person can't really chat through them or walk through them. They have to breathe and focus and often vocalize. And then between that full dilation then to that patient wanting to start to push, there is transition. Transition can be really messy and can be quite alarming for somebody who hasn't attended to birth, because transition, often the person is yelling, often really vocalizing. You do get very quiet people too, but it's less common. And they can start vomiting and shaking and vomiting. Often for us as midwives, we use the knowledge and the communication of, this tells me that your baby's soon to come, you know, that this is normal physiology and you're okay, this is part of transition. And it's very, very intense. A lot of people will not be able to hear instruction during that time or walk during that time, so it'll be slow progress to get into your ambulance and then to the hospital if the person's that far along. And then second stage is pushing. The contractions are likely, they have very little breaks between them at that point. Usually that person is feeling an urge to push. They might describe it as the baby is coming, I've got something between my legs, or I need to go to the bathroom. And if a person looks like they're trapping their breath and they're actually exerting pressure down and they say they need to go to the bathroom, then that's when you'd be saying, you know what, I need to check your perineum. I need to see if that sounds like the baby's coming. And so your big job is obviously load and go. However, you're going to have to distinguish, is this birth imminent? And if it is, it's better to stay put and set up and do the delivery wherever you are than in transport. If you've got a ways to transport, then obviously you can get in your rig and try and make it as much of the way there, and then the understanding is that for birth you would pull over, stop, set up, deliver the baby and continue on. But if the baby's right there at the perineum, especially for a primip or a multip, it's better to get set up, and we'll be going over that today. Third stage, so delivery of the placenta. One of the first signs is you would see a gush of blood, and that amount of blood can vary. It can be a trickle, or it can feel like half a cup that you're visualizing, and you might see the cord lengthening, which means that placenta is separated from the uterus, and so it's coming down in the lower bowl of the uterus, and so you see that umbilical cord lengthen out of the vagina. And then if there's contractions too, if the patient's reporting cramping, it is best to deliver the placenta at that point rather than leave it in the uterus. And you can imagine why. If that placenta is separated and sitting blocking the cervix, the uterus cannot contract and cramp down where that wound site is. So you've got internal bleeding. The uterus can fill up with blood, and then next thing you know, you've got a patient in shock. So what we know is if the placenta is in for more than 30 minutes, you're increasing your risk of postpartum hemorrhage by 6-fold. So if you've got a bit of a distance, obviously a baby's born, doesn't seem like the placenta's coming, you're going to get into the ambulance and get to hospital. But en route, if there is bleeding, patient reports bleeding or cramping, it may be prudent to stop, and we'll show you how to deliver the placenta and then continue on. So mechanisms of labor and birth, these are the key steps of how a baby gets born. And the one that happens all the way through labor is descent. So with every nice strong uterine contraction, the baby's entering the pelvis more and more. And then flexion is what we call where the fetus's chin comes right to chest. What we love about a well-flexed baby is this occiput presenting is the smallest diameter. So when you've got a well-flexed babe, so you've usually got a baby just like this with chin down, then you have an uncomplicated delivery. This occiput with the bones here can all overlap nicely and fit through the pelvis. If you've got a baby that's deflexed, that often, it's going to be a really, really long labor until that baby flexes, or those are the ones that often need manual rotation with forceps or a C-section. So those flex babies are most common, and labor helps that flexion as well. And then there's internal rotation. So the way this works is the maternal pelvic inlet here is widest left to right. So often babies do come in a transverse position. And as they descend and they flex, once it meets the pubic bone, it actually, thanks Shirley, it actually will swivel and rotate most commonly to this position. And that's because now deeper in the pelvis, the widest diameter is anterior posterior. And so once it's done that internal rotation, then we've got birth. So with a primip, you might see bulging perineum and then a little bit of the top of the baby's head, and then with more and more pushes, eventually the baby's born by extension, so it runs its face over the perineum and then you see the head born. What's interesting is you can't see those internal mechanisms, but what's happening now is the shoulders are following the same flow. So they come in left to right, and they eventually, once the baby's born, they turn into the anterior posterior position as well. And then when you see that baby's head restitute, that means the shoulders are now in the widest diameter, deep in the pelvis. So what we really will go over later is you really want to wait for restitution. So you wouldn't want to try and deliver the baby with its head like this, because its shoulders now are not ready to come. They're in a tighter diameter, and you can actually cause the baby to be stuck if you were to pull down. So we really do recommend you wait for restitution. That means the shoulders are turning. You'll see a small restitution, then you'll see a full, if you've seen birth, you'll see that full face turn. And then as what we call next is expulsion, so birth, and we'll help you follow the curve here. So typically you put a little bit of pressure down until you see that anterior shoulder come, and then you follow the curve up like this, and then baby's born. So those are those mechanisms of birth which are all happening internally. So in terms of assessment, you're going to be assessing in accordance with your BLS pregnancy standard. You're going to have the skills to determine if this patient is in first stage of labor, so dilation with active contractions, or if they're actually pushing and the birth is imminent, or if the baby's born and you've got the placenta in and that needs delivering. We'd ask that you screen for complications, which you all likely do. Do you have a history of hypertension? Were you diagnosed with diabetes in your pregnancy? Is it your first baby, second baby? How far along are you? What's your gestation? And so determining if the birth is imminent. So with primips, we say if the presenting part is visible, then that's imminent. Okay, so primates can take a couple of hours to push. That passage has not been stretched to give birth before, and so it can take a couple of hours to get that baby born. However, if you're seeing the tip of the head, then that would be considered imminent birth, and you'd be setting up. A multip is a little bit hard to discern how long you have because they've given birth before, and it actually can be quite rapid. So you may not see the vertex of the fetus at the perineum, but if the waters are broken and there's really strong contractions and that multip feels like pushing, that birth could happen in 2 or 3 pushes. So that's where it's a little bit harder to determine, should we get in and go? I would say if a multip's saying they have a strong urge to push and you're seeing, if you know how to time contractions, so the spacing is you start timing when the person vocalizes. You can even touch the fundus and see that it goes really hard, or visualize it goes tight and red. So you would start timing your contraction then and see how long it is. If it's a full minute long and then the next one comes in 3 minutes, so they're 4 minutes apart, because you include that length of that duration of that first contraction, and the next one comes in 3 minutes, and there's also a reporting of an urge to push, then that birth we would consider imminent. Basically, OBAG says, in their medical directive, that if you've done your best to assess and you think that the birth is imminent, but in 10 minutes of your initial assessment there's no change, you're not so certain anymore, then best to load and go. Okay, so now we're moving into setup for imminent birth. So this is what you're all skilled at. You stay calm, you keep your voice really steady, and privacy is a really big one. If you can maintain privacy, then that's excellent, and that you're there to reassure that patient and that family. Optimize safety. Obviously you think about all of that stuff being on the side of a highway, or wherever you're located, that the area is safe from being hit by traffic or whatever else is going on, and that you're going to gather your equipment and supplies. So you have your standard OBS kit You have your personal protection equipment, your NRP equipment, and any additional baby blankets you can get would always be good. We do say that if it appears, if the patient says, yes, I'm healthy, it's just the baby's coming quickly, I've had prenatal care and everything's been perfect, then really it's best not to intervene. Intervention, so sort of bright lights, lots of noise, lots of questions, lots of activity. There's a psychological aspect to labor and birth, and there is a way that that can stress that patient out, potentially stress the fetus out, and it is best to do nothing than to over-intervene in a normal labor, right? So it's kind of a relief to know that just your presence, having sterile gloves, that you're there to support that baby being born is valuable, and you don't necessarily need to do a whole lot when it comes to a normal labor and birth. So we generally recommend that you're going to assist that patient when you show up and you've determined birth is imminent. Your steps are you're going to encourage that person to be on a firm, flat surface. So if they're on the toilet, you're going to get them hopefully onto the floor. And we say flat and firm because if we have shoulder dystocia or because it's not your everyday work, you want to make sure you have good support, good visual access, good lighting. And so that is a good position for that patient to be in. If they refuse and they're on hands and knees, then birth can happen in any position. And if it's going well, you might as well leave that patient like that. But if there's time and the patient's amenable, then supine or side lying or supported upright is a good way to go. You really want to be able to get those legs flexed and abducted and to widen the pelvic outlet and that the perineum's visible. So often later in the day we say if you have your rig here and your stretcher here, it's really good to look at how would you manage a breech birth or a shoulder dystocia in your environment. And other training programs we've had to pull the stretcher out and figure out how do you actually hyperflex both thighs. It doesn't work just to hyperflex one. You need both out if you've got sticky shoulders and some of the other things we'll get to. You really want to try and keep that area warm. When babies lose heat rapidly, that's hard on them in terms of their metabolism and extra oxygen consumption. And so we recommend a plastic sheet, sterile drape, towels under the buttocks. You're going to wash your hands and put on sterile gloves. So crowning here, we have general, sort of gentle support of the perineum underneath, and then guarding the delivery of the head so it's not rapid, and we'll go over that technique in the hands-on. And really, if it's precipitous, you're encouraging that patient to pant at that time, allow that slow crowning for the tissues to stretch and for the head not to be born explosively. And then the biggest thing is figuring out how to assess for nuchal cord. So we'll put a cord around the head and get you used to, after the head's born, feeling is there a nuchal cord. So it sounds terrible, but 25% of babies have a nuchal cord around the neck, and it's not dire, it's very common. Our first step that we would say is after you've assessed that, oh yes, there is a ropey-like thing, I think there's a cord there, and if you did gently feel a pulse, that's a cord. You would see if there was some slack to it, and you would gently pull that cord just gently and see if there's slack, and you would loop it over the head as your first step if there was enough slack. If it was too tight to loop over the head, you could consider, does it fit around the shoulders as the baby's coming? Could it fit that way to be born? If it feels too tight to even do that, we recommend a somersault maneuver where you can actually tilt that fetus's head towards maternal thigh, and then the baby is born, and then you would unwind. It's last resort that you'd want to clamp and cut the cord at the perineum. The reason why is now you've cut off that oxygenated blood flow to babe, and you really want to make sure that baby's coming. There's no shoulder dystocia. You want to get that baby out. So if you can leave that lifeline intact for the birth, then that is optimal. Sometimes it could be occasionally 2 or 3 times very tightly around the neck, and if you're feeling it's impeding that delivery, then what you do is take one section of the cord, clamp in 2 spots, and cut between, right? If something happened where the cord actually tore, then that's a real emergency. That baby would be bleeding out its own blood. So if the cord snapped and the blood is bleeding out, you need to clamp those two ends immediately and get that baby delivered and utilizing its lungs for oxygen. So here we just have one technique where you're actually going lateral over the ears. You're putting downward traction to follow the curve of the pelvis and the sacrum, and then up and over. And very much providing warmth, skin to skin. You're going to dry and stimulate that baby and assess that newborn's transition as normal after. And this baby's restituted, so the head is turned, so you know the shoulders are ready to come. So third stage, obviously you leave the placenta in and you go if there's no concerns. If there's bleeding and cramping and you're concerned that the placenta is separated, this is how you deliver it. So your clamping and cutting of the cord, we do really recommend to allow the cord to pulse. If the placenta is attached to the uterus, there's still oxygen exchange happening for the baby. It's a natural recess as they dance between getting that oxygen from the cord and utilizing their lungs, expanding their lungs and expelling all their mucus. So after 2 or 3 minutes, baby's crying, pink, that cord has pulsed a while, then this is when we'd recommend clamping and cutting. It's actually not integral that the cord clamps and cuts. If you didn't, say you lost your OBS kit, you wouldn't need to go out of your way to clamp and cut that cord. That baby can stay attached to its cord. There is no dire consequence in a singleton pregnancy. If it was a twin pregnancy, then we're concerned about that twin gestation in utero. If there's twin-to-twin transfusion, you would really need to figure out how to clamp and cut that cord of that first baby. So you're clamping about 15 centimeters away from the baby's umbilicus, 2 clamps, and cut between. And you're going to wait for that signs of placental separation before you act, and I've gone over those. The key to delivering the placenta, which is really important, is that if you made an error, if you thought, oh, the placenta's detached, I saw a bleed, but it was actually a perineal tear, and there was a bleed from the perineal tear and the placenta was actually still attached in the uterus, if you were to just pull on the cord, you could actually cause uterine inversion. So the whole uterus could come out if you pulled really hard and the placenta was attached. That's why there's a lot of fear around the skill of delivering a placenta. So you'd only deliver it if that person was bleeding and you really thought the placenta was detached and ready to come. And we'll go over it in detail, but the key to guard that uterus and protect the uterus is you actually put pressure here above the pubic bone in the lower uterine segment, and you actually guard the uterus like that as you use downward traction of the cord. So you'd be guarding the uterus and creating downward traction, and you would feel, oh, there's no resistance, it's coming. And you'd wiggle the umbilical cord up and down until the placenta come. And usually we'd say hyperflex those thighs, get that patient to push, and if there's a contraction, all the better. And then it is like a second birth, but no big bones and all of that, so not as uncomfortable. So the key here is guarding the uterus, putting pressure up, and then the downward traction of the cord. And then we will go over inspecting the placenta as well, really checking out how you would look at the edges and the membranes that come. So immediate postpartum, another key piece of the medical directive is the simple technique of external uterine massage. You wouldn't do uterine massage with the placenta in. If you were to fiddle with the uterus with the placenta in, you could cause a partial separation. So we only recommend external uterine massage when the placenta's gone. The reason why is the uterus is a contractile muscle, and if you actually grab it and start rubbing it, it contracts. And so that wound site of the placenta, it alleviates bleeding from that site because now you've got a nice, good, strong contraction. So we'll be going over that uterine massage after, and you will feel it like a grapefruit through the patient's abdomen when you do that massage, and it contracts nicely. And it's not comfortable for them. It does cause some discomfort, and so you would say, you'd explain, I'm getting your uterus to contract because you're bleeding too much, so I'm sorry it's uncomfortable, but I have to do it. And then most people go, okay, you're doing something to help my bleeding. And And the other key here is if you can get the patient to void, that's really useful when it comes to hemorrhage. We know that a full bladder impedes the ability of space internally for that uterus to contract down nicely. So as soon as a patient voids, that uterus contracts a lot more efficiently and effectively. So that would mean free voiding anywhere. If you've got a bucket, a pan, towels, anything to try and empty that bladder. And then newborn, you've got your routine immediate postpartum care, dry, stimulate, skin to skin. Routine suctioning is not recommended. The way to position that baby to allow the mucus to drain is that head-dependent position, leaning forward, and just get that baby to cough, sneeze, get all that mucus out. Obviously, you can wipe it with gauze or your glove as needed because they're obligate nose breathers. And then the new guidelines for meconium are actually that you treat these newborns as you would clear fluid now. Are you all aware of the 2017 meconium guidelines through NRP? Okay, so it used to be if a baby's born with meconium, you're not stimulating, right? You're waiting to see if you need to intubate and suction. And now it's you treat that baby through meconium, you dry, stimulate, you do all your first steps as you would for a baby through clear fluid. So the medical directive wanted to make sure we included these most current guidelines. Obviously intubation is still part of your process for resuscitation as needed for those babes, and you've got heightened awareness because there was meconium, but you would just wipe that mucus and fluid from the baby's face and assess accordingly. Okay, so that's the first section, and now Shane's going to take over for the next one.
So we've talked about the normal birthing process and what to expect with no complications. Now we're going to start to get into some of the denied or hidden pregnancy, which is the next section, and then we'll move on to complications. Okay, so we know how it's supposed to happen in an ideal setting, under perfect conditions, with everything in order, all of your equipment and your gear ready, and all the prenatal care you've had. Right, so that's what we want to have happen, but we all know that the reality is that we need these skills here to deal with complications of pregnancy and delivery. Okay, so the next section here is denied or hidden pregnancies and other at-risk populations with limited prenatal care. So how many people in the room have had one of these patients or cared for one of these patients who either denied it outright, said, no, I'm not pregnant, or had some sort of complications with hidden pregnancy? How many people in the room?
Fake contractions.
Fake contractions before?
She was an alcoholic during the whole thing and denied it, and she was 8 months pregnant.
Okay. So certainly we'll talk about the incidence of psychiatric patients. I had one that was memorable was a lady thought she was pregnant with raccoons, and obviously that was not the case. But she swore up and down. So we'll talk about some of the examples you guys have seen in the field and how to manage those types of patients, obviously. So the second module, as I said, highlights the denied or hidden pregnancies. So a denied pregnancy refers to a person who is unconsciously denying the existence of the pregnancy. A hidden pregnancy is a concealed pregnancy. So this is either they're hiding it from their partner, they're hiding it from their family and friends. So they know and they're aware but aren't actively telling people, right? Their colleagues and the general public. Just for some statistics, the prevalence of an unknown pregnancy in the first 20 weeks of gestation is only 1 in 475 pregnancies. When we move into the second half of pregnancy, the incidence is 1 in every 2,455 pregnancies. And then the rarest is or the most prevalent is at delivery, which is 1 in 7,225 pregnancies. So if they've denied the pregnancy all the way to the stage at which they're delivering the baby, that's only 1 in every 7,000 patients. So has anybody had one of those 1 in 7,000 patients that's denied it all the way up until they're actually delivering? No? So certainly it's rare, but these are cases that we need to be aware of. So when we look at the risks of denied or hidden pregnancies, obviously they're high risk, okay? A lot of times there's limited or no prenatal care, there's no prenatal education or screening, and they don't generally know the health of themselves or the health of the infant, right? So when we look at some of the risk factors here, general health of the fetus, serologies, STIs, gestational age, adequate growth, placental location, position of the fetus, whether it's a primip or a multip, and any vital sign screening, so things that would maybe catch if they've got eclampsia or preeclampsia, gestational diabetes. In the event or in the absence of prenatal care, newborns are at an elevated risk of poor outcomes. So we generally look at these patients having preterm births, small gestational age for the newborn, and death. So we just want to talk quickly about other at-risk populations that we certainly are exposed to or that we care for with limited prenatal care. So pregnant and homeless or underhoused populations, certainly there's an increased exposure for things like violence, poor nutrition, substance abuse or misuse, reduced access to that care. Patients that are pregnant and are substance use disorders definitely have a higher rate of infectious diseases and STIs. Certainly psychiatric conditions, and there's a whole gamut of them that your patient might have, less likely to receive that antenatal care, and so a lot of that is putting them at risk. So the thing to remember is obviously this population not having that antenatal care and not knowing some of these risk factors, and if they have a substance misuse problem, it more than doubles the risk of preterm birth. Okay, and those are the patients that we've got to be aware of. So how do we manage these types of patients or this vulnerable populations? So there's obviously, you guys are used to dealing with these types of patients and with your assessments and your questioning. Obviously all the questions that you would ask a pregnant patient in your normal assessment of a pregnant patient, you might add a few more questions right around the care, if they did have care or not, and what types of disorders, psychiatric, what types of substances they've used. Certainly those questions would be included in your assessment. So we want to really use an empathetic approach when we are managing these patients. So some tips to remember, and you guys do this on a routine basis with all of your patients, but certainly when you're managing these types of patients, remember these things. So making eye contact with them, allowing the patient to speak, right? When you ask a question, allow them time to answer. Actively listening, right? Giving them nods, acknowledging what they're saying. Using their own words to summarize back to them, right? And using simple language, right? We have a lot of medical jargon and acronyms that we use. Obviously trying to keep the language simple and asking simple questions will help them understand. And the best way to care for the fetus or the newborn is caring for the pregnant patient. So the health of the pregnant patient always comes first, and the care for the fetus follows that. Okay, so just keep that in mind. So one of the first malpresentations we're going to be going over here is shoulder dystocia. Two of the new directives, or two of the new maneuvers that we're going to go through, which are in the new ALS medical directive under managing childbirth for out of hospital, is the McRoberts and suprapubic pressure. So we're going to go through and look at how to do those things, and then you guys are going to get hands-on and demonstrate that. We'll try to figure out how we can use the McRoberts maneuver as well when we bring the stretcher and the ambulance, and we can take a look once that gets here as well. So let's look at what shoulder dystocia is, okay, and the incidence, and then how to manage it. So by definition, the inability of the fetal shoulders to deliver spontaneously or in response to gentle lateral flexion of the head. So the description, and we'll demonstrate obviously with the pelvis and the baby this afternoon. Shoulder dystocia occurs when the anterior shoulder becomes impacted against the symphysis pubis, or the fetal posterior shoulder becomes impacted on the sacral promontory of the pelvis. So incidence is actually quite low. I think we as paramedics probably are exposed more to these higher risk populations and these malpresentations. So in our mind, this happens more frequently. Typically, the incidence of shoulder dystocia is only 0.2 to 3% of all vaginal births. So it's a quite low number. But you guys obviously dealing with these higher risk populations are probably more exposed to these patients. One thing to note, it is higher in diabetic patients and large babies. Estimated rate of recurrence in subsequent pregnancy is about 12%. So if they've had problems with shoulder dystocia in the past, it is more likely that they will in the future, but not a guarantee. We're going to look at a two-step approach for delivery, and some of the major take-homes that I learned here is a lot of this is we don't want to rush. Okay, when we look at these, I think we often have pressures and timelines that we want to meet. And I know in my initial training as a paramedic, it was always, okay, we're going to rush to clamp and cut the cord. That was something that I felt like it was urgent. When we look at some of these malpresentations as well, I want you guys all to remember just to slow down. Okay, do not rush. We've got time. We'll give you time frames for when to load and go and when to stay and manage your patient. But I want you just to keep that in mind. We're not rushing to do anything here. We will stay calm and allow the mechanism of labor to work. So as Annabelle demonstrated this morning, the normal process of delivery, a few of the things we want to keep in mind is once the head is born, there's a pause and a rest, and that's a normal process. So once that head is through the vaginal opening, we want to just allow that pause and rest, and oftentimes after that rest there may be another contraction and you'll have restitution after that. So allow that time for that head to turn or restitute. And that, as she explained, right, allows the shoulders to kind of turn and get into the normal position to allow it to pass through. So there is up to 4 minutes between contractions is normal. So just keep that in mind, right? 4 minutes may seem like a long time on a slide here, but it may seem like an even longer time when you're in the process of assisting a delivery. So just remember to slow things down and know that the 4 minutes is normal. Allowing the second step to deliver does not increase the risk of fetal harm and may actually lower the incidence of shoulder dystocia. So if you are trying to rush the process and not allow that restitution to occur by putting any traction or anything on the head, obviously that could cause shoulder dystocia to occur. So just make sure you're taking your time, and it's part of the normal physiological process. So assessment and considerations here. So what are we looking for when we're looking for signs of shoulder dystocia? So when the fetal head emerges very slowly, the chin may have difficult sliding over the perineum. So often we look for that chin or that tucked position, that flexion of the chin to the chest. If it's not and you see that the brows are coming out, be aware, right? Once born, the fetal head retracts against the perineum, and you guys are familiar with the turtle sign or turtling, and I'll demonstrate that as the head comes through in the normal process. What you may see is that as it's trying to move down into this position, if it comes out like this, you want to hold that? So as it comes out, you may actually see at the end of the contraction that it doesn't actually deliver the head, and it will pull back or suck back like that. So that process it's just not in the right position. So if you see that turtle sign, that could mean that obviously the baby hasn't restituted and the shoulders are not in that position. So you want to make sure that you're looking for that as a sign of shoulder dystocia. Okay, so that turtle sign or coming out and then retracting back in.
And for how long is this? Like,
How long?
like if I see it, it happens like once, just a little bit. I may assume it's part of the construction and the pushing, and then the muscle relaxing, and the baby goes back. But how do I know the difference?
When it's normal versus not normal? It's a good question.
So often in that pushing stage you will see, which is very normal, is the head comes down and rocks back. The head comes down and rocks back. We describe it to our clients as your tires stuck in a snowbank. You know, you're rocking back and forth. And that's normal. You've got to stretch that tissue and pave the way. When you get to the perineum, there will come a point where it stops rocking and you've got full crowning. And you're like, okay, there's not really a rocking back there. What we see with shoulder dystocia is it's not really spoken of as malposition. What it is it's a bony disproportion. So you've got either a big babe and a small pelvis. Sometimes you can have small babies that get shoulder dystocia as well. It's sort of considered a bony incompatibility. So as that head's born, what you see is, you can see cyanosis. Suddenly that face goes kind of blue, and you see the cheeks puff up because now it's contracted back, because this babe is hung up on the pubic bone. Are you okay, jump in?
Yeah.
Yeah, so as this head is born by extension, you've now got really puffy cheeks, and you've got perhaps cyanosis, and the reason why is this shoulder is held up by the pubic bone. So now you've got a really stretched neck of the baby, and the head's getting pulled back in. You know you've got shoulder dystocia there. Rarely do those babies restitute when that shoulder is stuck behind the pubic bone. Okay? That makes sense?
That's your question? Yeah? Perfect.
Just a question about restitution.
Sure.
I understand there's left and right. Is there how can you say, one more prevalent than the other? Is there an anatomical way it comes out, or it could be either way?
For which way it's going to turn?
Yeah.
Yeah, it all depends on where the fetal back is. So some patients will say, my baby's been lying left side. So if baby is coming in the pelvis with left side, you're going to anticipate the head turning a certain way. So you'd want to visualize that flow of the baby, which we can do on the
The
head.
reason why I'm asking is, I'm obviously no manipulation involved, but you don't, if you had to, you don't want to turn the wrong way.
Exactly.
Do you know what I mean?
Yeah.
So I guess
Yeah, that's why it's very much hands-off. And so you wouldn't go to force restitution if that's what you're curious around, because that would just be manipulating the head, which isn't the issue. The head's born. The issue is the internal body. So you can't really do anything to the head other than damage. So what it is changing the patient's position, which is where we get to McRoberts and suprapubic pressure to get that baby born.
Yeah, great question. Again, it's very hands-off for a lot of this, right? And slowing it down. So keep that in mind. So we talked about the cyanosis of the fetal head. Restitution rarely takes place spontaneously when it is stuck like that. Expulsive effort with contraction and gentle lateral flexion of the head fails to deliver the shoulders. So considerations in this point, so critical irreversible hypoxic injury to the newborn happens at 8 minutes after the birth of the baby's head. So we have that 8 minutes, but that's the number you want to keep in the back of your head. Strong traction on fetal head is associated with greater likelihood of things like brachial plexus injury, and it's not an effective technique for dislodging. So as we mentioned, we'll look at two of the techniques, the suprapubic pressure and the McRoberts, to position mom and help allow the baby to pass. So let's look at some associated factors and complications here. So there's a number of statistics up here. I'm not going to read them all out, but you guys can take a look as we go through the next two slides around complications with the neonatal, the birthing patient, and intrapartum. So oftentimes, I guess, like I mentioned before, we think of these incidents as happening more frequently because we're probably exposed to more of these high-risk pregnancies. But the rates are very rare for most, including hypoxia, asphyxiation, and death of the neonate. So So we're going to look at the management here. So number one thing to remember is ask for assistance. So whether that's asking for assistance from the patient themselves, a family member, for example, when we're putting them in the McRoberts position, even a second crew, right? Because you now know that, okay, you're the first crew on scene. You may be a first response unit on scene, so making sure that we're asking for the resources we need. So get a second ambulance called because you potentially could have 2 patients that you're dealing with, or even 3 when we talk about multips or twin delivery this afternoon. You want to ensure a firm, flat surface. So what does this mean for you guys? Making sure that you've got a firm surface, whether that's getting them on the floor, off of a bed or a couch, and positioning them on that surface. Elicit patient help for positioning and pushing. So using mom and coaching mom, using your communication skills to position her. And we'll talk about the importance of being really direct with your communication and explaining to them that we have to move you into this position to assist with the delivery. And if we don't, there is risk, right? So being forceful or being firm with the patient and explaining to them why you need them to move into the hands, onto their hands and knees, for example. With documentation, obviously we know that's important, and we'll remind you through the scenarios of what kind of documentation and what kind of time frames you want to remember to document. So time of the head delivery and time lapse between the maneuvers that you're trying is important. Oftentimes our documentation is done after the call is over, but this is one example where we want to make sure we kind of look at the times and jot a note down as to what time mom started having contractions, what time the head was delivered, and a number of other times in the sequence of events. And that way we can communicate that to either midwives on scene or if we're having a conversation with our base hospital physician to look for assistance. Those times are going to be critical. So we're going to learn an acronym. We know that in paramedicine we love acronym, and so we're going to throw another acronym at you here. Whether you like to use it or not, these are the steps and the things that we want to remember, okay? So if you want to write this down or jot this down, it's ALARM. So it's a series of steps and maneuvers we're going to try when faced with shoulder dystocia. So A, ask for help. You're going to require at least 2 people. So certainly a secondary crew is important to request at that point. L, you're going to lift the legs and hyperflex the thighs. And we're going to practice this, but we'll actually figure out how we're going to be doing it on the stretcher in the back of an ambulance, so you guys can take a look. And this position, or this lifting of the legs and flexing those thighs back, is called McRoberts maneuver. A stands for, so just actually a note, with McRoberts maneuver, that actually relieves, just doing that McRoberts relieves the majority of shoulder dystocias. Let me just see the stats here. So at the bottom you see it resolves shoulder dystocia with 23 to 40% of all cases, okay? So that's quite a number. We know the incidence of this, and so if we're just following these steps, typically on step 2, that does relieve most of the shoulder dystocias. If we do move down to A, so abduct the anterior shoulders and apply suprapubic pressure, so we'll learn how to do that with the mannequins later on, and how to apply that pressure and how much pressure to apply. The next one is a rollover. So we're going to actually get them into the Gaskin maneuver, so the hands and knees position. So we're going to, if they were on their back with legs up in McRoberts, we're going to actually get them to turn and get onto their hands and knees. And just the positioning of mom will oftentimes move the baby. Just that movement can help dislodge the shoulders. The last one is manual delivery of the posterior arm, and so we're actually going to check for the hand or arm if visible with the perineum, and then assist with the delivery of that posterior arm. So we have a couple of slides here just to show you what these positions and maneuvers look like. The McRoberts there on the left is getting them right up and hyperflexing those thighs. And obviously, if you can imagine in the back of your vehicle with the cabinets on the one side, even if you have a center mount ambulance with the stretcher right in the center, you might have a little bit more room, but certainly you're limited for space here. So foot in the cabinet, opening the cabinet and taking out whatever's in that cabinet by mom's right leg might be the best and only position that you can utilize for transport to the hospital. Remember, we're trying these positions unseen because we know that we're in the process of staying unseen and delivering, but certainly if things aren't progressing like we talked about with the time frames earlier, then this might be something we have to do en route to the hospital. Okay. On the right hand side there, you can see applying direct downward pressure or suprapubic pressure, and that's done right above the pubic bone there, and that's to actually put pressure on that shoulder, right, to help it pass. We're going to get some practice, like I said, once we have the ambulance and the stretcher here, just on positioning with these positions.
Can I add something there?
Sure, yeah.
In general, with shoulder dystocia, my experience with working with paramedics is often the real goal is like load and go. Like if something's really quite hard to manage, it's load and go. This one's a kind of unique one. You really do want to get that baby born. So if the head's out, it would be very rare that you'd be transporting in with just the head out, because that baby's not going to make it. So really the thinking is you need to get that baby delivered. So what Shane's gone over the alarm, we would expect you to the whole way through mentally be saying, we can get this baby born, we can get this baby out, and really working through those steps with that intention to get the baby born. What we're recommending in collaboration with OBAG is if the lead paramedic goes through alarm and the baby does not come, then we would ask your second to go through alarm again. Because really, you saw the slide that 8 minutes is irreversible hypoxic injury to that babe. So you've got that first sort of 10 minutes where you really are trying to get that baby born. And that second paramedic likely would be able to get that baby out. Maybe it's like trying to open a jar and somebody's loosened it for you. You know, you've got that second set of hands, second technique. And usually that hands and knees, that Gaskin maneuver, is very effective to just change that fetus's position, dislodge the shoulder and get that baby out.
How long do you attempt each maneuver for? It's like just a couple contractions and then you try the next one?
That's a great question. With these maneuvers, you're not really waiting for contractions. This is an emergency response that's going with your own flow. So if you feel you've got that patient's back really flat, you've got excellent hyperflexing of the thighs.
The baby should just deliver.
And then you've got suprapubic pressure, you're going to try that. And that's nothing to do with contractions. You're just trying that technique. And if you're like, no, this is not coming, and you really want that person to push that shoulder down, which we'll show you, and that baby's not coming, then you move to your next one. So that might take 15, 20 seconds at the most, that one maneuver. And then you're going to rolling over onto gasket, right? And then looking for that posterior arm. You can imagine if you see a hand or feel an arm and you deliver that, now you've got reduced diameter inside that's inhibiting delivery. So you've at least got the arm delivered. And so that second paramedic would go through. If you truly couldn't get that baby out, then yes, you would be transporting in. But the thinking is you want to go through them twice and going, and that would be very rare.
So think of a blaze or 2 alarm. Just repeat that, the first paramedic, and then the second paramedic tries again.
Realizing there's only 8 minutes to really sort of play with, and you're only 3-4 minutes from the hospital, would it not be beneficial just to kind of stabilize that patient?
With the head out?
With the head out?
Like you're only a few minutes from the hospital?
No, your entire focus should be on getting that baby born.
Mm-hmm.
gotta remember your transport time too, right? Like that's
Yeah.
3-4 minutes, but by the time you get in there, by the time the physician gets there, the nurses and stuff, that's all adding up, getting the patient out of the ambulance into the yard, all that time adds up pretty quick.
So what I'm saying is you wouldn't be faulted if you're only like around the corner from the hospital, but you messed around for 8 minutes on scene to try to deliver it, and if you couldn't deliver it, and now you transport it? Would
No,
you get faulted?
and that's the teaching from Ontario-based hospital group with this program, is that we're going through and we know the 8-minute time frame, but it would be prudent to try the alarm twice and go through that and then make the decision to transport. If you attempted and then also documented that you attempted twice with 2 different paramedics, still wasn't progressing, yeah. I mean, the only case there, and there's always shades of gray or areas of gray, if you're on the steps of the hospital, then you might make a decision to move them in to try these maneuvers with the assistance of the staff there. But certainly, like Dave mentioned, right, 3-4 minutes in travel time adds up to a lot more by the time you even safely, how are you going to get mom out of the house and walking with the head presenting, like all those other things to consider, right? So certainly trying to deliver and staying on scene and going through your alarm twice is what we're teaching. Yeah, is the best thing. Yeah. Another question? Yeah.
So realistically speaking, say you were at the doorstep of the hospital and the mother is presenting like this, is there really anything that the hospital would do without having a labor and delivery team available, like working in a more rural setting, that they would do that we wouldn't do?
No, this is a hands-based skill.
So they're going to do the same thing.
They're going to do exactly the
So
same
we
thing
might
as
as
you
well
guys.
stay on scene and do it ourselves.
There
and take that.
there are a few additional things
Okay.
that midwives and physicians can do, but
Okay.
these are not bad skills. These are not nothing skills. They are effective skills.
Right.
The things that they can do would be things like cut an episiotomy,
Okay.
but usually it's actually not a soft tissue.
It's the bones.
It's a bony disproportion issue. Cutting an episiotomy would help the practitioner put their hands in. So often, some of these maneuvers we actually do internally. We grab that shoulder and rotate the shoulder internally. Because vaginal exams and putting your hands in the perineum aren't part of your scope except for cord prolapse, you're doing the external maneuvers. So that's why the time frame is do them twice. For medical legal reason, do them twice to try and get the baby born. If you can't get the baby born, then yes, you are at risk of not expediting them into hospital to get those additional things that a physician's going to do.
Okay.
Right?
But it's not so much more. So.
No, and
Stay
shoulders
around
is
and do it
about
how-
position and your technique. Yeah. Yeah.
There are some other things we'll talk about later where there are additional skills. Yeah.
I've had 2 of the shoulder dystocia, and these things work.
It was, yeah.
Shane and teacher said that they did the McRoberts and right out after.
Yeah, and that previous slide that talked about the statistics, certainly, a good majority is relieved just with the first alarm, right? So even just getting to the McRoberts maneuver, and if you've worked your way through alarm and then the second medics work their way through as well, chances are that it is going to deliver.
I think it's hard because we're taught like go, go, go.
Yes.
So just like realistically remembering that what are they going to do so much differently than what we're going to do on scene.
Yeah.
After a certain point, obviously, to get going, but...
Exactly, and that's why we're learning the skills, the hands-on skills, and the majority of today is the hands-on practice, so you'll get comfortable with doing these maneuvers and the positioning and communicating and going through this, because this is what you should be doing on scene. Yeah. So I know it's always rush, rush, rush with everything, and that was a big thing for me to have to, digest is, okay, slow it down, right? Hands off, right? Mom's going through the process. These are natural processes, but even if it is complicated, the maneuvers that we're looking at here certainly should alleviate a lot of the complications, right? So immediate postpartum management of shoulder dystocia. So for the newborn, we want to evaluate the neonate. Obviously, if we need to go down the neonatal resuscitation pathway, I always remember the neonate or NRP pathway as kind of an upside down triangle, right? And if you always start at the top, and the majority of the time that works. If you're getting down to the bottom where you're including needing to use ventilations or needing to get down where, you know, compressions or intubation or drugs, which is there at the bottom of that pyramid, you should always remember, start back up at the top. You've probably worked down that pyramid too quickly. So most of the time you're not dealing with a full neonatal recess, but obviously evaluate for the need after the delivery. One of the other management considerations are a pneumothorax. So there is a potential complication with a fractured clavicle that it could puncture and cause a pneumo. So assessing, auscultating, looking for those signs and symptoms. The birthing patients, there's obviously increased risk of postpartum hemorrhage from tears and internally as well. Assess for bleeding from perineal trauma as well. So make sure we're looking for those things. With this, remember part of this, the documentation here, some of the things you want to consider when documenting for all births, but with shoulder dystocia, color of the fluid and time of the rupture, time of the birth of the head, shoulder dystocia, maneuvers attempted and when they were attempted, time of the birth of the baby, time of the placenta or delivery of the placenta, and then estimate the amount of bleeding, so whether it's minimal, moderate, whether there were clots or not. So making sure those things are all documented. So any questions about shoulder dystocia? Okay, and you guys are going to get practice doing the scenarios and hands-on this afternoon. So we're going to look at breech birth next. In the ALS medical directive here, we're going to learn a new maneuver, and it's German, you had said? French? French? I'm not sure the origin of the word, but morceau smelly vite maneuver. You may, as we say smelly vite, you may hear it referred to as smelly feet maneuver. Okay, but we're gonna try to remember the morceau smelly vite maneuver, and we're gonna learn how to do that. So the definition here, the fetus is in a longitudinal lie with the buttocks as the presenting part entering the pelvis. And we have a number of types of breech presentations here. Certainly the complete breech is about 10%, and the frank breech is about 70%. So between those two at the top there, that's typically how they will present in a breech presentation. Certainly a footling breech or a knee presentation are a lot more rare. So by definition, we know that they're in one of these positions. The incidence of this is only 3 to 4% of all term pregnancies deliver as a breech. So again, we're probably more more likely to see a patient with one of these breech deliveries or breech presentations, but the incidence is quite low. 10 to 25% or a third of all breech pregnancies are at term or not diagnosed prior to labor, so that's one thing to know. When we look at associated factors for what might cause a breech presentation, there's a number of maternal as well as placental fetal processes. So you can take a look at the list here. If they have had a previous breech, for example, one Australian study estimated that there's a 3-fold increase in the risk of breech presentation in a second pregnancy. So screening and asking the mom for around some of these risk factors will give you an idea if that's more likely. Even multiple pregnancies may limit the space, so we'll talk about that when we look at the twin deliveries this afternoon. And so there's a number of other factors here to be aware of. Do you want to expand on any of those there, or no? Any questions about what's up there, guys? All right. Some other associated complications. So when we look at cord prolapse, head and neck trauma, for example, these are all things to be aware of when we're looking at the etiological process. So assessment and considerations for a breech. So signs of imminent breech birth. Fresh passing of dark meconium at the perineum. Breech, leg, or foot may be visible, so you're looking for what type of breech presentation it is. We want to encourage the birthing patient to empty their bladder, and this is always a good thing to remember. Making sure you're freeing up some space. So getting them to void, and whether that's where they're laying, making sure that they're passing or emptying their bladder will allow more room there. The aim is to birth the baby within about 4 minutes from the birth of the umbilicus. We want to minimize the cord handling to avoid vasospasm. So by actually manipulating the cord, you can cause vasospasm. So again, a hands-off approach. And controlling delivery of the fetal head is essential. So we'll teach you how to guard the perineum, and that's just to reduce the explosive or a quick delivery, right? So controlling the delivery is what you're doing there with your hands. So remember, with a breech, hands-off breech, allow gravity to birth the baby, and we're actually going to show how to position mom, probably have mom elevated and on a flat surface, but elevated to allow that gravity to help the birthing process. So what does it look like? These are some photos here, and you'll see the Morceau Smelly V maneuver there is the last slide on the bottom right. And we'll, actually, I guess we can demonstrate here for you guys. Do you want to be my assistant there? So as you can see, you've got the hands, your fingers actually over top of the shoulders. And your bottom hand, it's hard to see where your bottom hand is here. Okay, but what you're doing with this maneuver is you're assisting, pushing down on the top of the occiput on the back of the head there, and then you're not grabbing into the mouth, obviously, being careful, but you're positioning your fingers there on the cheekbones, so kind of this position. Okay, and as you progress through, you're flexing up, you're tilting up, and it's kind of an up, 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 down, down, down.
This is crowning, so this is when you'd actually get panting. You'd pant, pant, pant as you're doing this Morceau Smelly V. And as Shane says, up and over. Up and over, and baby ends up almost a somersault. So they're kind of somersaulting out, right? So got the weight of the baby here, fingers on the malar bones, hooked over, and that's all about encouraging that smallest presenting part, that occiput, and encouraging flexion. So just remember, hands off until we get to this maneuver where we're doing the chin, assisting with chin to chest, and then up and over onto the chest. One thing I was going to say, if you show up and the patient says, yeah, I'm having the baby right now, and they think the baby's vertex, they think the baby's head down, but you then see like a toothpaste tube of black come out, so that fresh bowel movement, then it's likely breech. If the baby was vertex, that meconium would mix with the fluid and come out like fluid. If you're seeing, you can almost see it here on this slide. The unfortunate practitioner that showed up and seen that coming out, you immediately know that baby's in the breech position.
So this is what we just kind of demonstrated here in a visual form. So support the baby's head, baby with the forearm, palm supports the chest. You're going to maintain that flexion and support the spine. And then fingers on the malar bones, not in the mouth. Apply that suprapubic pressure to promote flexion. And then place the dominant hand on the baby's back, 2 fingers over the shoulders, and then the middle fingers on the occiput to maintain flexion. When the nape is visible, lift the body to pivot the head around the pubic bone and allow the face to be born. So just as we demonstrated there. Minimize the handling of the baby. Obviously, potential damage to internal organs causing bone fractures. Avoid stimulating premature respirations, so that's important to note. And then control delivery of the head. We can wipe the nose and the mouth when visible. Again, remembering the changes around, it was always drilled into our heads around meconium, and when you see that visually, and what are the things you have to remember. But just review your 2017 neonatal guidelines around the care and a process for meconium, right? be prepared for neonatal recess. Obviously the incidence might be higher for fetal hypoxia, so just be aware, have your station set up and all your equipment ready to go if possible to deal with complications. So here's your breech flow chart. So you can see that from the start on the left-hand side, working your way through and allowing gravity to birth the baby, and a very hands-off approach to breech is what you want to remember. All the way to the very end, which would be the Morceau-Smiley-Vite maneuver. So just keep that flow chart in mind. So immediate management of a breech birth. So evaluate, obviously, as we did before. Do not attempt to pull the legs down if folded out or folded up. If the baby has been in the breech position for some time, it's normal for a baby to have a square head, so just be aware visually. And this will resolve within 24 to 48 hours, and we know why. Increased risk of postpartum hemorrhage, obviously, for mom, and assess for bleeding.
I'm sorry to hear that, and part of the assessment we're walking you through is what would be some of the signs that this is actually an undiagnosed twin pregnancy. You've got one baby there. How might you suddenly clue in, oh, potentially this is a multiple gestation. This person didn't have much antenatal care. And so we'll go through that. So obviously twins is when two embryos develop in the uterus at the same time, and twins account for about 4% of the births in Ontario, and up to 20% of twins will not be detected prior to birth in the absence of an ultrasound scan. Okay? It's really hard to palpate and figure out sometimes that there are two babies in there. So without ultrasounds, you've got a risk of 20% of twins not being recognized. And multiple gestations, triplets or quadruplets are very rare. We do see an increase in twinning because of the use of ovulation induction and artificial or assisted reproductive therapies and delayed childbearing. So as maternal age increases, we see the incidence of twinning increase. The main associated factor and complication is that these babes most commonly come early. So we spoke about term gestation being 37 to 42 completed weeks is considered a term gestation. With twin or multiple gestations, it's a little lower. 36 to 37 weeks is considered term. That's when those twins babes are more likely to come. Obviously they can go longer, but that 36 to 37 week is considered term in twins. Anything less than that is preterm, and there is an increased likelihood of twins coming earlier. You can imagine with a really distended uterus, two babies growing in there, you run the risk of postpartum hemorrhage afterwards. That, you know, having that uterus contract down after the birth can be harder, and there is a link with hypertension. And with the babes, there can be growth restriction, and often patients with twin pregnancies have a lot more monitoring. Part of the physiologic condition is twins either share a room or share a fridge. There could be one placenta or two placentas, two amniotic sacs, or sharing one. And as a paramedic or a practitioner that doesn't know the person and doesn't know there's twins, the concern is, well, is there one placenta or two? Do we have a twin-to-twin transfusion here? Are these fetuses healthy? You know, there's a lot of consideration. So if you were to show up and that person had had very little antenatal care and they actually didn't know they were having a twin pregnancy, one of the first ways you might see it is that first baby might look quite small, like smaller than what you were expecting. If you saw her, I don't know, if she reported being quite large and then you saw this little baby, you'd think, what's going on there? And then you might see that the fundus still remains quite high. So you would ask to palpate, and you put your hands on the abdomen just above the umbilicus and see if it felt like you could feel fetal parts inside. Okay, and that would help you clue in that this is a twin pregnancy. So that would be very much a load and go. You're trying to get into hospital as soon as possible. The reason why you would stay if the birth is imminent, if that patient has strong contractions, you see vaginal bleeding, or obviously if there's a presenting fetal part of the perineum, you're going to stay and manage that second delivery. After the first baby is born, 80% of the time there is a 20 to 30 minute delay prior to the birth of the second baby. So depending on when you got there, you've got around 20 to 30 minutes before the next baby wants to come. So you know, depending if you're rural and how far away you are, you might be able to get in time. As I was saying before, we don't know if the placentas are connected. So the risk of that is exsanguination of that second twin inside if you allow the cord to pulse of that first one. So if they're connected, the majority of that shared fetal blood can go to that twin A. So if you figure out you've got twins, the first thing you're going to do is clamp and cut that cord. And we do really recommend that you would clamp once for twin A. If twin B did come, you might want to really try and mark that that's twin B and put 2 clamps on, or mark it in some way that reminds you that that's twin B. Because the pediatrician's going to want to know when you come in which one was born first, and that's going to be really hard to know. So if you're suspecting twins, obviously you're going to provide immediate newborn care to that first baby, and you're going to clamp and cut that cord. And then you visualize the perineum before you head off to see if there's a cord prolapse, if there's anything presenting out, a limb or bleeding, and then you're going to urgently transport unless that birth is imminent. And if that birth is imminent, you're going to go ahead with a normal vertex birth or a breech birth, as we've learnt in the other 2 modules so far. Yeah, so we've really gone over clamp and cut that cord. I think it's hammered in. You're not going to let that cord drain, as we've discussed before. Let that cord pulse. And if the placentas are ready to come, that's a key piece you'll need to add to your toolkit today. That if you were to see 2 cords coming out, you might be thinking, do I deliver one and then the other? You deliver them together. So if there's a gush of blood and the cord lengthens and that it seems to you like those placentas need to come, you would actually guard that uterus as I showed you earlier. You'd grab both cords together and you'd do your downward traction. You'd wiggle it up and down to follow the curve, the sacral curve, until those placentas came. And you can imagine now that uterus is really distended and it had 2 big placentas. So you've got 2 wound sites inside. You're going to want to do external uterine massage on that patient and really encourage that uterus to contract and control that bleeding after a twin pregnancy. And with all of these, we say use your pregnancy standards for resuscitation or good preventative care, that, you know, if it's within your scope to start an IV, then you would be giving a bolus, especially for a twin pregnancy. Even with breech, if you're showing up and there's time, you would consider always an IV, because if anything changed and you were rushing in, you're looking at C-section with a lot of these issues. So if IVs are in your scope, you would be placing an IV. The medical staff are going to love it if a twins person delivered out of hospital and came in with an IV, because the first thing they'd do is likely give oxytocin and just make sure that uterus is really nicely contracted and that there's been fluid replacement with potential excessive bleeding after the birth. So the next one is malpresentation. And this one here, OBAG came up with this in the medical directive. Perhaps this has happened to people before, but this is clearly a baby cannot be born in this position. So these babes are transverse, and you just can't have a vaginal delivery this way. These babes would likely be delivered by C-section. This one, you can see this placenta previa. That's even more alarming. That's placenta's covering the cervix, so you would see somebody hemorrhaging with labor. As that cervix dilated, that placenta would bleed from there, and any of our patients that have placenta previa would need to have a C-section. This one, the limbs presented, there's often probably a thought, would I push that limb back in, or what would I do? The recommendation is you do not push that limb back in. You would actually encourage that patient to lie on their side, maybe exaggerated Sims position, so elevate the pelvis with some cushions, just sort of an anti-gravity, and you'd cover that limb with a warmed blanket and transport in. Okay.
How do you differentiate between that and a breech? The
Well-
limb presentation breach.
Yeah, good question. So if, here you can see it's an arm, you'd probably figure out that's an arm and not a foot. If a foot was dangling out, you would do the same thing. If birth isn't imminent and just a foot's hanging out, you would cover it with a warm blanket and get right in. If the client's pushing and the baby's coming, that would be really a struggle for you to figure out how to get that other leg delivered safely. But we could go over that in our hands-on, but it's not common. If that person's not delivering and the foot's just hanging out, you're treating it as limb presentation, covering with a warm blanket and going in.
Would the mother know? She probably would know if she had a placenta previa because she had ultrasounds done.
Yeah, some patients decline all ultrasounds depending on your population, but usually there's a warning bleed at sort of 28 weeks. So if you were to say, you're bleeding quite a bit, have you bled in your pregnancy? And they said, yeah, I actually had a bleed but it resolved. Or have you had ultrasounds? No. Then that tells you don't know where the placenta is, and it could be placenta previa. So basically, malpresentation is any fetal position other than head down. So breech, footling, transverse, and transverse is 3 in 1,000, so it's not common. But if you've got somebody having their 4th, 5th baby, it's sometimes a bit more common that baby will just fall into whatever position it wants. And it's more concerning for us as practitioners when we have people that are having multiple pregnancies and their babies seem to just be moving all the time, and you just hope that eventually the cephalic or vertex position is the one it's going to take. Often the patient will say, I'm feeling the head on this side, and so you might say, do you feel a heaviness in the pelvis? If they say no, the pelvis feels empty, and they're actually quite far along, but their uterus is out like this rather than up like that, then that's one way to identify that baby's lying sideways. And if you've got contractions, you just need to get in. So that's not going to be a easy vaginal delivery. So yeah, we've talked about signs of it, that it would be a really wide or asymmetrical abdomen. The patient reports feeling the head on one side. The fundal height is lower because the bulk of the fetus is lying this way. And some patients may be aware that the baby's got malpresentation. They might have been told by their physician or their midwife that, if your bag of waters break, you have to call EMS. Because the risk with a malpresentation is if the head isn't nicely nestled in the pelvis like a plug, you run the risk of cord prolapse. So if you're told that it's transverse and your bag of waters break, you could get a call from a patient saying, my baby's transverse, my bag of waters broke, I'm worried that the cord is prolapsed. And so your initial job would be to visualize that perineum and see if you can see anything, or ask the patient if they can feel something hanging in their vagina. And you can get them to put their hands right there and see if they could feel anything. Yeah, so I went over this with the first slide, how to manage that limb presentation. And that's an urgent load and go. So a big change for you with the umbilical cord prolapse is the directive to actually place your hand inside the patient's vagina to manage this emergency. This is actually life-saving for this fetus. If you don't do this, you really run the risk of this baby running out of oxygen. And so I'll go over why this is a life-saving skill. Okay. So when the bag of waters breaks, if the umbilical cord slips out beyond the baby, so the baby wasn't nicely descended in the pelvis or was malpositioned and the cord came out, then that's considered a cord prolapse. So it's come out right into the vagina. It's quite rare, 0.1% to 0.6%. It's more common in these malpresentations like breech or transverse, and it is an acute emergency. You can imagine here that you've got the weight and the compression of the fetus and the patient's bony pelvis, that as soon as the fluid's gone and the cord's there, the understanding is you've got cord compression. So if you've got cord compression, then there's no oxygenated blood flow to the baby anymore. So it's an internal resuscitation that needs to take place, and it's just with your hands. It's digitally, manually elevating that fetus off its own cord to allow the blood to flow. So that's how you're maintaining that life support for that baby with this technique. So again, signs are right there. And as I've explained, it can lead to fetal hypoxia or death, increased hypoxic damage or asphyxia. Imminent birth with cord prolapse is really rare, but if you were to show up and you had a multip, so second or third birth, and you see the head coming and the cord is there, you wouldn't shove the head right back in off the cord. You would expedite birth, right? So if the head's right there and you see the cord too, you'd go, oh my gosh, we have a imminent vaginal birth and a cord prolapse, let's get this baby born. So the way to expedite birth is actually using gravity. You'd get that person upright and you'd really clearly instruct them to push as hard as they could, okay, and get that baby born. If any of us were to attend to a client out in the community and there was a cord prolapse, we'd be calling in saying we've got a cord prolapse, we need OR ready. So often it's unfortunately putting the patient under general anesthetic and having an emergency C-section. Because as we know, you've really got 4 minutes. When we looked at the breech delivery information, the reason why we use 4 minutes is that's how long you've got with cord compression. We give it a bit longer with shoulders. Hope I don't muddy the water here for you, but with shoulders we gave it 8 minutes. And that's because there's a consideration that if the uterus is in a low tone situation, it's not charging and pushing and contracted, that there is still some blood flow to that baby while you're trying to do the maneuvers to get that baby out. With breech, you've now got that baby hanging out. You see the umbilicus, there could be cord compression. That's why we say 4 minutes. With cord prolapse, you really would have 4 minutes too if you left that cord compressed. So with that multip giving birth at home with the cord prolapse, you're likely going to get that baby out in 4 minutes to expedite that birth in that scenario. Is that clear? Makes sense? Okay. So the way to manage it, what we do as midwives at home is just from all of our ESWs over the last 20 years, we always put people in knee-chest position. And the thinking is you're actually using anti-gravity to help you out. So you're changing the position of that fetus down off the perineum and off the cord, and so that's one technique to help you. It's not going to completely eliminate cord compression though. You'll need to wash your hands, put on sterile gloves, gently cradle the cord. As Shane was saying, with breech, if you were to handle the cord, it can cause vasospasm, and it doesn't like being dry and cold. It can spasm. So you'd actually want to cradle the cord gently in your hand, place it into the warmth, moist environment of the vagina, and push the presenting part up and off the cord. So we'll go over how to manage that with the techniques today. I know for transport, this is a problem. It doesn't feel safe driving to the hospital in this position. So a lot of paramedics say they would actually use exaggerated SIMS. So they would lie the patient on the side with their pelvis elevated. So you've got a pseudo anti-gravity here, put the pelvis up on 2 pillows, and do this same technique with the patient on the side and feel like you could transport a bit safer. The problem with that is if you have somebody with really strong contractions, it is absolutely exhausting to counteract a uterine contraction and keep the fetus off the cord without this position helping you. So you'd have to figure out how you want to safely transport.
Like, how do you know, like, you don't want to hurt the baby's head, so how do you know, like, how hard you're going to push, just until you palpate a pulse and then that's it in the cord?
It's a good question. When you're holding the cord, depending on your adrenaline and the thickness of your glove and everything,
in an ambulance, right? So you're going to be bouncing.
Yeah, you might not be able to. You might just feel it pulsing, and that's going to be reassuring. You do want it to have a nice, fast pulse rate. You know, if you're feeling 50 or 60, that's not great. If it feels slow, like 1 a second, you'd actually want to push more, because it's still being compressed, right? And unless birth is happening, it's better to really encourage that pressure on the fetus and keep it off its cord. So yes, you may hurt the head in some way, but you're keeping it alive by encouraging it to not compress its oxygen supply. And it is the standard technique for cord prolapse when you're out of hospital.
Your arm will be shaky.
That's how much pressure you need?
Yeah. The force of uterine contractions if they're in strong labor is, So up north, if they're going by Orange Air, they're doing this the whole way. And those babies come out screaming if you've been able to do it. You've kept their blood supply going.
When we did the Teach the Teacher course, I don't know if it was you, but one of the midwives apparently was off work and had to have physiotherapy, and because she had to hold it for so long and push so hard that she actually injured muscles and stuff in her hands and her arm, that she had to go physio and was off on comp for it.
And that's often to do also with the amount of time, right? So like, if your transport is very short, then you're still going to feel pretty shaky and it's going to ache. But if you're having to do it for a very long period of time, then you can hurt your muscle.
So here they show a picture with 2 fingers, and that's less common. You often have to fold your hand and place it in the vagina to actually get to the fetal head. And then you're going to call ahead to the hospital. So when do you think you would remove your hand once you're in?
Never.
You don't until somebody else, a physician or a labor and delivery nurse, is there to take over. So you wouldn't remove your hands unless there's another hand to replace you. What we would do as midwives is go into the OR, would have a drape put over us, would be under the bed until that baby's lifted out through C-section.
This is why you need to ensure you call for another crew as well, because you can't do anything else. If something else happens, you're stuck, so make sure you get help.
So the baby, you're not delivering the baby then, like that's not the point. The point is to get the patient to the hospital, in which case then we would have to transport from there.
Yes.
We don't have
Yeah.
labor and delivery.
Yeah. The only time you would deliver that baby is if that baby's right on the perineum, ready to be born, and the cord is there too.
Okay.
Then you would expedite that birth.
Okay.
But no, probably 99.9% of the time you see a cord prolapse,
So the whole
you're going
point
in.
is to shoot the baby inside, so that's how much pressure you're
Yeah.
putting in.
Yeah.
Okay.
Yeah. And elevate it off the cord.
Okay.
Yeah.
You can see that, just on the last slide, we mentioned the exaggerated SIM position, so you can see the two pillows there, and so we'll practice that when we actually have the stretcher and positioning there, so it's exaggerated semi-prone position.
Great. So now this is our last module, okay, and then we can take a break and get into the hands-on. So this is postpartum hemorrhage, and what's being added to your scope is external uterine massage, and we've talked about that quite a bit all the way through. And so what I'll really go over is when you would do this uterine massage, which is really important, and when you wouldn't, and why. So for postpartum hemorrhage, if we have a vaginal birth and we estimate about 500 cc's of blood loss or more, that's considered a hemorrhage with a vaginal birth. But really it's any amount of blood loss that causes that patient to exhibit signs and symptoms of shock, because everybody responds differently if they're hydrated or not, if they're anemic or not. And also clinician error. It's really hard to determine and to estimate how much blood there is, and from practitioner to practitioner you're going to have different estimates. So studies have looked at that and said as soon as you add urine or fetal fluid or blood loss over time, it's really hard to estimate. So the key thing is if it looks like a very big gush and then you have a patient turn pale and look like they're going to shock, you're treating it as hemorrhage. That primary hemorrhage happens in the first 24 hours. And that's about 5% of all births in Canada. And then a secondary hemorrhage can occur if that patient's day 2 now, like 24 hours have passed, or anywhere up to 6 weeks postpartum is that secondary hemorrhage that can occur. Often that's retained tissue. So if there's a little bit of retained placenta, that can be a cause of this late postpartum secondary hemorrhage. So the causes of PPH, we really like to think of the 4 T's. So it's tone, trauma, tissue, and thrombin. And we really focus on tone, which is the tone of the uterus. So if the uterus is tired, it's been a precipitous birth, or it's been a really long prodromal labor and birth, if there was a shoulder dystocia, so a traumatic birth, if you had twins, that uterus is distended, so all that plays into tone of the uterus. And this is actually results in 70% of postpartum hemorrhages. That's why we focus so much on uterine tone, because it really is the vast majority of hemorrhages. Trauma, often you can get a cervical, not often, sorry, occasionally you can get a cervical tear and a perineal tear. And so any tissue tearing, you can get bleeding from there. From trauma, sorry. And then tissue, we mainly talk about retained placenta. And that's a much smaller amount. And then thrombin are blood clotting disorders, which again, likely we would know if that person had antenatal care. So really with postpartum hemorrhage with you guys, we're focusing on tone and a little bit on tissue and trauma. So your acronym would be CRA. You're going to communicate, and then you would say to that patient, you're losing a little bit more blood than I'm comfortable with, and that would alert your backup. Okay, we've got a bit of a bleed on our hands. You're going to initiate your resuscitative measures, O2 therapy if you can, consider an IV start and keep that patient warm. And then your A is the big one. You're going to arrest the bleeding. Well, what's bleeding? Is the placenta in or is the placenta out? Is it a perineal tear? What's going on? So this is the next steps are you trying to figure out why this patient is bleeding. Generally, you're going to have that patient in a recumbent position, going to monitor their signs, and ensure that they don't eat or drink anything at this point. If this is a retained placenta that needs surgery, you don't want them eating and drinking en route to the hospital. So there's 2 different management steps for if the placenta's in or if the placenta's out. If the placenta's in and that patient's bleeding, your first thought will be, I need to get that placenta out. So it's likely separated, the uterus can't contract, and she's free bleeding. So if you're seeing a significant bleed and the placenta's still in, you want to get it out. You're not going to massage the uterus when the placenta's in. Like I said, that can cause partial separation and create a problem. So you don't want to be fiddling with the uterus when the placenta's in. And you're going to attempt to deliver the placenta as we showed in the first module of normal placental delivery. You're going to guard that uterus and do downward controlled cord traction, get that patient to push with the hyperflexing thighs, and hopefully the placenta comes. You would then perform external uterine massage to cause a nice contraction to control that bleeding. And usually that works. If it is tone, it's really needing to massage that uterus until you can feel it firm. Sometimes you can be massaging an abdomen saying, I can't feel it, I can't feel it. We call that a boggy uterus. It needs stimulation. So there are other ways. You want to make sure that bladder's empty. You can encourage nipple stimulation by the patient themselves or get that infant latching. What we know about the physiology there is that releases oxytocin, which is what the receptors lining the uterus grab, is the oxytocin to help it contract. So we have a direct way with nipple stimulation to surge the body with oxytocin to get that contraction. And then we can manually do it with our hands. The only time you would do, I've added external bimanual compression, and this is very unlikely you would do that. But in the event that the patient's bleeding and the placenta is not coming and the patient's still bleeding, you would do your resuscitative measures, and then you would attempt external bimanual compression, where you would actually It's like wound compression, what you would do. You would push here and see if you can grab the uterus with the placenta in. And that is a way to compress the uterus and the placenta while you're transporting in. And if the bleeding stopped, then that is your problem. There's been a partial separation, the placenta's not coming, and this is a life-saving skill. What midwives do is we do internal, so we would put our hand in and compress. But that isn't part of your scope, so the next best thing you can do is this external. Grab the uterus here and hold it all the way in. But I hope none of you ever have to do it, and it's unlikely you would, but that is something that you would do. If the placenta's out and the patient's bleeding or unstable, then that's when you'd want to rub up a contraction using your external uterine massage technique. And you really want to keep massaging. You wouldn't give up. You'd keep going until you felt it firm up. And it usually is central. If it's far off to one side, the bladder's full, so you'd want that patient to void. If you were to push down on the uterus as well, you might see a bunch of clots come, and that's good that they're being expelled, because if those clots are clogging the cervix and the uterus is filling with blood and it can't contract, you do want to contract the uterus and expel those clots, and then you'd probably have a more stable patient if you did that. And again, if the placenta's out and that patient is still bleeding and you're concerned about the tone, you would again do that external bimanual compression as you transport in. If you saw a perineal tear, we're recommending you take some sterile gauze and you compress that wound. So it's that wound compression to stop it from bleeding. And here's a picture of that external bimanual compression. Some studies have said that you'd have to do this for 10 to 20 minutes at least to create enough compression to cause hemostasis, but some studies also say it's even longer, so you may want to spell off if you were ever in the event of doing this, that the next person might come in and do that. And then we'll go over visual inspection of the placenta as well. If you've got the placenta out and the patient's free bleeding, you might say to your partner, can you check the placenta? And then if your paramedic looked at the placenta and saw that a big chunk was missing, then you'd say, oh my gosh, we've got some retained placenta inside. And that's just great for your report when you go in. You'd say, we've brought the placenta, it appears complete, or we've brought the placenta and actually it looks like a chunk is missing. You know, and you wouldn't be at fault if you saw signs of separation, you saw bleeding, the patient was contracting, the cord seemed longer, and you went to deliver the placenta. It's not necessarily anything you did that created that piece to stay inside. That's usually an abnormality in placental growth into the uterine muscle. And so then you would just say, I think some of the placenta is still in. So that's